Hello and welcome to our webinar, Amplifying Unheard Voices, Unique Symptom Presentation and LSVT Care for Black Women with Parkinson's. My name is Beth Peterson and I'm an SLP with LSVT Global and one of the LSVT Loud faculty instructors. I'll be moderating the presentation today and I'm joined by Valeria Gary and she'll do the main presentation of content. So we're delighted to have her share her expertise in this area. And so we'll go ahead and get started. We have some more information in your handout about Valeria, but we have just some basic information. She does a lot. She wears many hats. So hopefully you'll see that through the presentation and in the handout. She has a lot of great information to share, but she's a Parkinson's and motor speech specialist. She's the owner of Thrive Collective Coaching, a mentor for the Medical SLP Collective, and then a speech language pathologist for the WellStar Health System. And I have a little more information in her biography here, which is in your handout. And then she'll talk a little bit more about her background as well. And with the handout, I'm just going to go over some logistics and I'll cover that handout as well. And so right now, everyone in the audience, your microphones are muted, and that's just to make sure that we don't have background noise from wherever you're joining us. But if you do have a question, there are a few ways to ask your questions. The first is to type your question in the Q&A box on your webinar control panel. And then I'll see that you have a question. Valeria's given some time towards the end of the presentation to answer questions, but if you think of them during the presentation, feel free to type those in. I'll save them and then ask her those towards the end. And if it's a technical question, I can get to that right away and help make sure that you can participate well in the webinar. You can also raise your hand during the Q&A portion. So if you click on that hand icon, I can see that you have your hand raised, and I'll call out your first and last name to let you know that I'm unmuting your microphone. And then you can also always email us. So if you have questions that you think of after the webinar, feel free to email us. It's webinars@lsvtglobal.com. And either I can answer it, or if it's something for Valeria, we can pass it on to her and she can answer it that way. And the handout I mentioned, so you should have received a handout in the pre-webinar email. I think that was sent about an hour before the webinar. And so that will have all the slides that Valeria is presenting today. And I'll also drop that in the chat box as soon as I get through this intro so that you have it there. It will also be sent in a follow-up email, and so you'll have access that way. And then I'll go over the continuing education information and survey in the next few slides. So for any speech language pathologist professionals in the audience, this presentation is being offered for 0.1 ASHA CEUs. So in order to receive that credit, you'll need to watch the 1-hour presentation in its entirety and then fill out the survey. If you're watching with us live, that survey will launch right at the end of the webinar when you X out. And it will also be sent in a follow-up email. That follow-up email is automatically sent, and I think it sends 24 hours after the webinar, so you can access it that way. If you're viewing on demand, the survey link can be found below the webinar description, either on our website or on our YouTube page. If you can't find it, feel free to email us and we can send you that link so you can access it. And just a note that if you're using this for ASHA CEU credit, we count all of our webinars for the year as one activity. And so even if you're watching this today, which is the end of September, it won't show up in your report until we report them all at the end of 2025. So just a note on that. And if you'd like a certificate, whether or not you want us to report to ASHA, you need to complete the survey also, and then there's a line in there to say that you'd like a certificate, and then we'll send that certificate within 2 weeks of your request date. For those in the audience who might be physical or occupational therapists, this isn't state registered for CEUs, but it can be used as a non-registered CEU activity. So very similar to the SLPs, you'll just need to watch the presentation and complete the survey, and then we can send you a certificate. And so then you'll have that for your records so that you can self-submit that. All right, and I'm going to save this portion for the end when we get to the Q&A section. And Valeria, if you're ready, I'll stop sharing my screen and let you take it away.
All right, thank you. I will start my share here. All right. All right, I want to make sure everyone can see that. Is it showing up okay?
Yeah, looks great.
Okay. All right. So here's the name of this presentation. My disclosures have already been kind of mentioned. I did want to also add, I have a non-financial disclosure, and that's that I'm an ambassador for the Parkinson Foundation's Georgia chapter, and that does influence some of the recommendations I have as far as resources and also how I kind of got actually involved in looking at the intersection of race and gender in Parkinson's care. A little bit about me. I work in outpatient neuro rehab and I run a consulting company. Of course, as mentioned, my specialty area is Parkinson's, and then my hobbies are writing, traveling, and competitive powerlifting. Now, my path to looking at this has been it'll be 10 years actually in November. I first became LSVT certified November of 2015. Before that, I worked with people with Parkinson's, but that's when I started to kind of really do more of a deep dive. I've presented, quite a few places on Parkinson's, but it wasn't until 2019 when I was asked to speak at a panel on women in Parkinson's that I really started to think about, what is different with the way that women experience Parkinson's versus men. I really hadn't, kind of delved into that or made any observations from a clinical standpoint. And then in 2022, I participated in a panel with the Parkinson Foundation on Parkinson's care in the African American community. And although I had been doing a lot of not research, but just kind of studying up a lot as far as like health literacy and health disparities, I had not really delved into how do we change or shape or, how does our care get influenced by race. So this started me kind of pulling things together and looking at, how different people come into our programs, like what their experience is like, what their symptoms are like, and then what can we do to better our care. So kind of pulling it all together. All right, so these are the objectives that we have for today. I'm just going to kind of skip over that. The agenda is a very loose agenda, but just kind of a quick introduction. So we know that nearly 1 million people in the US have been diagnosed with Parkinson's, and that number is expected to increase to 1.2 million by 2030. About 90,000 people a year diagnosed with Parkinson's. And when we look at the incidence of Parkinson's and how it varies by race and ethnicity, we see quite a few different studies. So the first statistics you'll see come from a study out of Kaiser Permanente, California. And then the second study was a comprehensive look by Dahawala et al. In 2010. And so we look at, as far as like the incidence, 16 in the first study, 16.6 per 100,000 Hispanics, but then the other study that's at 40 per 100,000. Non-Hispanic whites, 13.6 per 100,000, compared to another study that says 54 per 100,000. Asians, only one of the studies that I've cited looked at the Asian population, 11.3 per 100,000, and then Blacks, the first study, 10.2 per 100,000, and the second 23 per 100,000. So we see we've got kind of a variation in those numbers, but it does let us know when we're looking specifically at the Black population, we're looking at a lower incidence than we see in other populations, in Hispanic and white populations. I did a very, very, very informal review of the Parkinson's literature, and I wanted just to see like the things that we go to for looking at like how do we do speech therapy. First, I started looking for Parkinson's, then I just started looking for motor speech in general. I wanted to see if studies were looking at gender and race when in the populations of the study, and I found that for the most part, unless a study says women and motor speech or Parkinson's, or African Americans and speech or Parkinson's, chances are those samples in those studies, a lot of times don't even mention what the breakdown is. I saw a lot of breakdowns as far as age in the study population. Some might say gender, but they didn't specify like how many men versus how many women. A lot of times they didn't specify ethnicity. So again, when we look at our research, we know that there's not a lot out there where we can really say specifically, this is what we know for sure about women. This is what we're sure for sure know about Blacks and our motor speech and also Parkinson's research. Some of the terms I looked up, women, Black, African American, Parkinson's, speech. I think also I looked up dysarthria, just trying to find how much representation there is. So the clinical impact is that, some of the treatment protocols, I'm not talking specifically just LSVT, but just in general, the things that we do in speech therapy, it may or may not reflect the experiences of diverse populations, particularly Black women. Looking at LSVT, as I was exploring the differences between race and gender with what we see, I don't see anything that says that anything in the protocol is not appropriate for Black women, but the way that we approach therapy, that's where we need to make sure we have some special considerations based on someone's path, to getting to us. All right, so a word about gender for the sake of simplicity. In this presentation today, when I talk about women or females, I am talking about females assigned at birth. There is really very limited, if any, real research done in the transgender population. We're going to talk about the role of hormones, estrogen in particular, in Parkinson's risk, but there is not really anything definitive about hormones as part of gender affirming care. So again, I just wanted to clarify what I'm talking about. All right, so let's look at some sex and race differences. So sectioning out race versus sex, these are some of the different areas that we're kind of looking at. So as far as like when do people get diagnosed or recognize their symptoms? What are the non-motor symptoms, the motor symptoms, cognitive symptoms? What does culture have to do, and also our research gaps? All right, so let's back into looking at gender differences as far as risk factors in the first place. So we hear a lot of the research saying that caffeine, people who tend to be coffee drinkers have a lower risk of Parkinson's, and that's found to be true in men, but not necessarily in women. When we look at caffeine, postmenopausal women on HRT or hormone replacement therapy may show an increased risk of Parkinson's. So there's a complex relationship between caffeine and hormone interactions, and we don't have a lot of definitive information about the roles of some of these things. When it looks at alcohol consumption, there is maybe a risk lowering effect that's more pronounced in women than men. Women gain more protective benefit from moderate use. It does not mean that if you drink more that you will have less likelihood of Parkinson's, but when we look at the correlation between those two things, that's what we see. Smoking, that's another thing we've heard. People who smoke tend to have lower risk of Parkinson's. Well, that's truer for males than it is for females. So that smoking, again, we quote unquote protective effect is going to be stronger in the male population. And another area where we look at risk is pesticide exposure. Parkinson's is associated with pesticides and Parkinson's only in men. Like there haven't been studies to show that there's a correlation with women. So some people say that suggests that there might be a biological protection for women, but then we also have to look at who is more likely to be exposed to pesticides. Like when we look at, from a career standpoint, is it that women aren't necessarily working jobs that increase that exposure to pesticides? So a lot of, possible correlations. We talk about causation and correlation. So we have some correlations, but we don't necessarily have definitive answers for these things. All right, hormonal research. So there's definitely, hormonal influence. There's definitely a need for more research in the relationship between hormones and Parkinson's, especially in diverse populations. But here are some things that have been found. So from an estrogen standpoint, a lot of studies feel like the reason why women are less likely to have Parkinson's than men is because there may be some neuroprotective properties within estrogen itself that helps to lower the risk. Estrogen can help prevent dopamine neuron death and reduce brain inflammation. We look at the impact of menopause. So menopause onset increases PD risk and severity, but then also, as we age, we have an increased risk of Parkinson's disease. And then looking at surgical menopause, it may accelerate progression. So that's where we're really kind of looking at perhaps there is a hormonal impact on that. Hormonal fluctuations, they can cause changes and influence with Parkinson's symptoms. So when I work with patients with, especially our young onset patients, if they're still, having cycles or they're still, going through the menopause phase, I let them know that, sometimes if you notice variations in your symptoms, you're not really sure why, take a look at how does that line up with your menstrual cycle. Because symptoms tend to worsen premenstrually and also during menopause. And then when it comes to hormone replacement therapy, there are mixed effects on Parkinson's symptoms. It has been found that combining estrogen and progesterone is more beneficial than estrogen alone. And I think that's probably more common practice anyway, to do that combination with hormone replacement therapy. All right, so let's talk about symptom presentation. I'm not going to read this word for word, but basically, so we have here motor symptoms, non-motor, cognitive function, and cultural factors. And then we have it divided by Black women, and white men. I did not do study as far as Black men because I wanted to tease apart just male versus female and then Black versus white. So if we look at a lot of the things, so Black women and white women share a lot of the things that are different compared to white men. But when we look at some of the severity levels, then things tend to be more severe in Black women. Some of this has to do with social determinants of health. And that's going to be like a lot of things are going to influence what your health is like, your access to health care, how you're treated in the medical system, your access to nutrition, all those things kind of come into play. So again, a lot of similarities, which really kind of makes us think about the estrogen factor, but then also some differences that may lead more towards life experiences. Like mental health, this is a big thing, especially for our female patients in general with Parkinson's, and it can certainly be exacerbated in our marginalized populations. Mental health is a crucial aspect of Parkinson's care. The prevalence of mental health issues, higher rates of anxiety and depression in women with Parkinson's, up to 50% experience significant depressive symptoms. Impact on quality of life, mental health issues worsen motor symptoms, and increase psychological distress and also lower self-esteem. Barriers to care, there's stigma and cultural barriers that might hinder help seeking, underdiagnosis and undertreatment by healthcare providers, the importance of integrated care. Again, mental health really should be part of PD treatment plans. And I know it can be really hard to get neuropsych consults and psychology consults in a lot of settings. But as much as we can, if we can help patients tap into that, is definitely should be part of their care. So if we can, collaborate with neurologists, psychologists, social workers, whomever in the community that can be part of that patient's team. And then support strategies like encouraging participation in women-specific support groups or Black-specific support groups, Hispanic, whoever that patient can connect with to help them to get tapped into the community, and then promoting mental health screenings tailored to women's needs. All right, so barriers, this is where we really see race come into play and where we see a big gap between Black and white women's experiences. So there are barriers to early diagnosis. Black women face specific barriers to early diagnosis, including delayed diagnosis, reduced access to specialists, and systemic healthcare inequities. There was a study by I hate if I'm mispronouncing the name, but Daho Dwala et al. And they found that African Americans are less likely to be referred to specialists, which can delay diagnosis and treatment. Additionally, non-motor symptoms like depression and anxiety are often overlooked, and motor symptoms may be misattributed to other conditions, further delaying diagnosis. And we know with Parkinson's, we really want to see people as early as possible because our interventions are just much stronger if we can, get the patient into our exercise programs from the very beginning. Dr. Branson, she's with Morehouse School of Medicine, and she's done some research. And her research has highlighted the cultural stigma and perceptions of aging that can lead to misinterpretation of symptoms in Black communities. So there's a cultural influence. So not only is there a delayed diagnosis on the medical end, but there's the delay in even just going to the doctor and saying, hey, this is what I'm noticing. I think there's something going on, as opposed to, well, of course I'm stiff, I'm getting older, or of course I'm weaker, I move slower because I'm just getting older. Bailey et al. Noted that disparities in access to care and underrepresentation in research studies make understanding the true differences in disease progression really hard to determine. Right, treatment disparities. So Black women are less likely to receive certain medications, especially some of the newer medications. Access to advanced treatments like deep brain stimulation is lower in the Black community. And what's interesting is that a lot of the centers that do DBS tend to be in urban areas, and yet people who live in urban areas don't necessarily get the same access to that particular care. So these disparities can lead to poorer health outcomes and reduced quality of life for Black women with Parkinson's. Another study, this is also Bailey, noted that newly diagnosed Blacks with Parkinson's are less likely to receive physical therapy or medications at their first appointment. And I'm assuming if they're not getting physical therapy at their first appointment when they're diagnosed, they're probably not being referred to speech therapy. The study talked about once prescribed, so once Black people do get the referral for therapy, they're less likely to utilize physical or occupational therapy. And again, I'm going to make also the assumption speech therapy. So then it comes to, okay, why is there less access? We have delayed access first, and then once the access is there, why is that not happening? And there are a number of reasons that we'll talk about. All right, so some factors that contribute to this. So socioeconomic status, healthcare access, and provider biases. These are things that provider biases is implicit and explicit that may affect the diagnosis and treatment recommendations. And of course, we know, again, looking at social determinants of health, socioeconomic status is a big factor. So the lower income and lower educational levels do correlate to greater disease severity. If lack of access to specialists or even being referred to specialists in the first place, having access just to general care, much less specialized care, can be a barrier for quite a few populations. All right, so looking at some of the key issues. So again, so research shows that Black individuals are diagnosed at later stages than white individuals. Historically, Parkinson's research has been centered on white males, so that leaves gaps in our understanding about how the disease affects women and other populations. Black Americans are particularly underrepresented in PD research, so that's going to limit what we can know about how we experience Parkinson's. And the evidence, there's evidence to suggest that Parkinson's disease does not manifest in the same ways in all racial groups. There are some variabilities, but we don't know enough about that without the representation. And then disparities in access to care and underrepresentation in research studies make understanding true disease difference and underlying reasons for these differences difficult to determine. So I know I've kind of flown through some of those issues because I do want to definitely make sure we have time to listen to a first person account and also to talk about what does this look like for the LSVT therapist. All right, so again, so the issue, diagnosis and treatment disparities, less likely to receive a diagnosis, missing out on crucial exercise programs, symptom misinterpretation due to bias. And this comes from an NBC News article on Black Americans with Parkinson's disease. I thought this last point was interesting. Facial expression seen as disconnected. So we know that a masked face or hypomimia is very common in Parkinson's. And what they found is that when someone comes to the doctor and they have these symptoms of Parkinson's, they have this masked face, they were often judged as being just like kind of disconnected, as opposed to, oh, there's something neurological going on with them. In this particular article, they talked about exercise considerations because we know exercise is fundamental. It's movement is medicine, but they were finding that there was a gap in Black participation in exercise programs for people with Parkinson's. They were having difficulty recruiting participants for programs. And so they looked at, well, why is that? So once we get someone tapped in, why is it not happening? A big thing was that there were privacy concerns. So a lot of people within the Black community feel like you don't share your business. That business that's house business. You don't tell everybody what you're going through. So that was one thing. Cultural reluctance to disclose health, not trusting other people to share their story. Representations within the programs themselves. So if there's lack of Black program leadership, if the people who are running the programs have limited cultural competence, if the programs are all led by non-Black individuals, that's not something that draws Black people into those particular programs. A big thing here, especially for our younger patients, is going to be the workplace fears. So, Black people often have to work really hard to achieve and to stay in a position and to get people to trust them and trust their skills. And so if we add a diagnosis that maybe people don't necessarily know about, on top of that, but they know it's something neurological, it can affect you. There's a fear of being seen as like sick or challenged. There's a fear of additional employment discrimination concerns. And then we put that on top of historical workplace bias patterns, and we can see why people would be less likely to disclose that they have Parkinson's. And so if they're not disclosing that they have Parkinson's, they're not going to join the Parkinson's exercise program, which puts them out there. And so that was a big part of the barrier. So some of the solutions that this particular article talked about was increasing Black leadership in programs, providing community micro grants so that people, you don't have to go elsewhere outside of your community to get those exercise programs, or bring it to where people are, building trust through cultural outreach, and then creating inclusive environments. And so, these are some things we can think of even within the context of our own therapy. It's like, what does representation look like? What do our programs look like? And how can we build trust with the community? All right, so you've got a couple of links. So some first person accounts. So one of them is from an article, Breaking Silence on Parkinson's in the Black Community. There were two people that were interviewed for this, two Black women, and one of them talked about how initially she kind of dismissed her symptoms as normal aging. Well, I'm having some pain, I'm stiff, I'm walking funny, but I'm just getting older. And once she was diagnosed, she did hide her diagnosis from her coworkers because she was concerned about being considered incompetent. She thought people were going to just assume right away that she couldn't do her job. A quote from this article, which resonates with a lot of Black women, is, being a Black woman, I was raised to never crack. You stand up and deliver. So, if you've had that message put through you all of your life, this is how you are, that if you're a Black woman, you're strong. You still deliver what you need to do. You still go through your day. You still take care of everybody. You take care of your job, your family, everything. Then yes, you're going to be probably more likely to put things on the back burner, and not take care of yourself at the very beginning. So a quote from that article: "It's not going to go away if we ignore it." And that's something that I would want to make sure that everybody with Parkinson's, but especially Black women, know that it's not going to go away if you ignore it. You've got to take care of yourself. Another article, this is Manon Day, Parkinson's Journey. I don't know her racial identity. I know that she referred to herself as a minority, but I don't know her specific ethnicity. But I thought her story was interesting because her symptoms actually began when she was 17 years old, but she did not get a diagnosis until she was 27. And some of the barriers to her diagnosis was that she experienced racism, prejudice, and medical incompetence. She said she felt mistreated and powerless within the healthcare system. And the most heartbreaking part of it is that clinicians mistakenly assumed that she was a drug addict when she was seeking help for her symptoms. So her quote is, "We need more awareness to break the myths and stereotypes around the condition. Parkinson's doesn't only affect old Caucasian men. It can impact anyone, regardless of age or ethnicity." Dr. Branson, again, movement disorder specialist at Morehouse School of Medicine, does a lot of work in this particular area. So I would definitely say, look her up, follow her. There's a YouTube video from the Parkinson Foundation. This was the one in 2022 on Parkinson's in the African American community. I was a part of that panel. There's a wonderful first person account by Taisha Blunt Dillon that I would say check out if you go to that YouTube link. All right.
Please.
Oh, okay. Sorry. All right. So now I do have an interview from a recent patient of mine, Dr. Florence Bell. We had trouble with the sound. Normally, like this video sounds nice, loud, and clear, but when we tried to share the sound, it's not so loud. So I added some captions to it so that you can hear it better. The captions are auto-generated. I didn't have a chance to proof them and correct any errors, but on the recording, we should have the sound a lot clearer. So Dr. Bell, again, patient, she received LSVT big, LSVT loud, and she participates in our Loud for Life and our Big for Life. You will notice how fabulous she looks on here, and she is not dressed up just for this video. This is how she showed up to every therapy session and to every group. So always looking wonderful. So I'm going to switch my screens here and stop that share and then share from the caption video. All right, and I'm hoping that this works well.
My journey to diagnosis of Parkinson was a lengthy one. I retired 2002, and for 30 years I worked hard and long, and the disease had not been discovered. I felt a clamor of twisting in my fingers. I said, oh, let me tell the doctor about this. And I ended up in an exercise program, strengthening my body. No diagnosis. It wasn't until 15 years later that the diagnosis occurred. The earliest symptoms was mild twists in your fingers and stiffening of the legs. I did experience tremors, but they were very mild. Initially, other symptoms that were identified and not identified as Parkinson were a need to strengthen your body. Your hands and arms need to be strengthened, lift weights. So I enrolled in an exercise program, the Human Performance Center. I went there for 11 years, 3 to 4 times a day, firming my body, strengthening my body. And that did take place. However, the twists that were occurring and tremors continued. I did not experience non-motor symptoms, and one of the reasons I believe it caused that to happen, I exercised, I ate right, I did the right things. I did not have any other non-motor issues. My experiences with the healthcare providers have been great. Everybody was cooperative, but I did not get the diagnosis that I should have had initially. I went to the health clinics, and at 2 of the health clinics, after I completed the 2-week program, it was decided that I should not be there. I should be on another program that takes care of Parkinson's or diseases like Parkinson. My treatments have been basically exercise program. But when I did meet a doctor who decided that it was symptoms like Parkinson, not Parkinson, but symptoms like Parkinson, I had medication that was given that would control the tremors, but it didn't stop the tremors. It just controlled it, and it was not noticeable. I have had barriers when you enroll in a program and it's not designed for you, there are ways that personnel let you know this is not your program. In 2 programs, I was told 2 weeks after participating that there may be another program you need to check with my doctor. This one was not the one that designed to take care of my needs. And I did just that. I checked with the doctor and found some other programs. You have to ask for what it is that you need. The program that I engaged in was exercise programs, health programs, where one would maintain your weight, read, interact with others on a small basis. There was nothing out there. Resources were not available. You just had to make do on your own. Design your own programs, and that can be very disruptive in one's life. I have been referred to 2 locations to assist me with my Parkinson. In the first location, I did what I had been doing for 15 to 20 years, exercising, and I know I did not want to go through that again. Then I had the opportunity to meet the Big and Loud Institute. And that's designed for Parkinson. Now I interact, communicate with health providers, know my way around, and enjoy my stay with the center. When I started with the Big and Loud program, I was heard the first day. I was asked to hum a note. Ah! And I said, what is going on here? But then on a regular basis, when I was humming notes and then putting other things with that program, I saw the complete picture. And I know now that interaction with others who are aware, others who know, you can do it too. You can surpass goals that you set that were not big goals, small goals. Now you aim for the sky. Give me the big sky. Family, community support, more family than community support have played a big role in my journey. Without family, I could not have made it. So with the family, they're always there. Doctor's appointments, meals, you couldn't do without them. And your faith got to be strong. I have not participated in any Parkinson research studies, and the reason being, I don't know any that are available. I don't see communication in reference to it. And I'm not that knowledgeable, and was not that knowledgeable to go out there and research on my own about what were the earliest programs available for Parkinson. But now, there are many avenues that have been opened through the Big and Loud program. More readings, more interaction, and it has helped a great deal. I would want the community and others to know that Parkinson is in Black women. Not the majority of them, not loud numbers. They don't make any noise because most of them don't know that some resources are available. I didn't know until I got out there to find out for myself. You don't see any resources in doctors' offices or in libraries. They have centers set aside for need and help for others with Parkinson. The word needs to get out. You need to spread the word. We need help. But we can make it when we interact with others. That is always a good sign. My advice would be work with Black women with Parkinson, just like you work with other women with Parkinson. But however, with this group, make the resources available like you do with other women with this disease. My advice to a newly recognized Parkinson individual who is female and Black, look for resources, talk to your doctors. If they aren't giving you answers, ask other doctors, interact with other Parkinson patients. You interact and find out you have a lot in common. Go for it.
All right, so I'm going to go back. She's just wonderful. I love her. All right, let me go back to my slides. All right, so there are a lot of different initiatives, looking at how to improve care for Black women with Parkinson's. But what I want to do is talk about what can we do as speech pathologists. So yes, we can, we could certainly help share resources. We can tap people into any community things that are going on. I know, for example, with the Parkinson's Foundation, we've been trying to work with local churches in order to disseminate information about Parkinson's. There's Parkinson's PD Generation, which is a global research study that provides free genetic testing and counseling for patients with Parkinson's. And so we're really trying to get a lot of good representation there so we can find out the role of genes and our genetic makeup in Parkinson's and Parkinson's care. But I'm going to go to this one. So culturally responsive LSVT loud services. So as I mentioned before, when I look at this difference in symptoms with women versus men, with Black individuals versus white individuals, the principles of what we're doing with LSVT are still the same. We still are working towards that amplitude. We still need to have the intensity. So that doesn't change. So we don't want to get away from the way the protocol is written. We want to maintain that treatment fidelity, but there's some things that we might need to do on the front end as we deliver the service. And actually, we probably should do a lot of this with anybody in our on our caseloads, but this is going to be especially important for our marginalized patients. The first thing is to build trust. So there's a lot of reasons why Black Americans have distrust in the medical system. There's historical things that have happened to us under the sake of medical care, and then there's just our present day experiences where we're often dismissed. People don't believe that we're, having the problems that we're having. So think about by the time someone comes to us with that diagnosis of Parkinson's and they've gotten that referral for therapy, they might have had those symptoms for a long time. They might have been seeking answers for a long time and not having the best relationship with their healthcare providers. So some of the ways that we build trust is explaining what our role is in their healthcare, describing like what's the rationale for the treatment and why the specific treatment techniques that we're doing are medically necessary. Acknowledging that being frequently interrupted during LSVT loud, that's a really important thing to do in the front end. Because if you think about it, if you've gone through your life, you've experienced a lot of racism, sexism, and all of a sudden you're coming to therapy, you don't know what speech therapy is all about, but all you know is someone keeps cutting you off every time you're talking and telling you to say that again, say that louder. That can, from a cultural standpoint, that could be considered to be very rude. So I try to let people know from the start that as soon as your voice drops to a certain level, I'm going to have to cut you off and have you to repeat that again louder and explain why. I say, this is an intensive exercise class, and I would be doing you a disservice if I didn't cut you off. I know it's rude to cut people off, but think about this not so much as a casual conversation, but an exercise class. And in that exercise class that your doctor has ordered and that is medically necessary, I have to do the things that research shows is going to help your body, help your brain to get the outcome that you want. So really kind of, describing things from that standpoint, I feel like, I don't get as many, kind of looks when I cut people off and with our LSVT protocol. Also, I'll check in with, someone's comfort level because, maybe we need to adapt how I'm cutting them off, but I have to do it. But maybe there's a signal I give first, and if they don't respond to that signal with increasing amplitude, now I've got to just stop you and give that, that feedback about, use your loud voice, give me your voice, all the things that we've learned to do. Also, we can kind of reframe how we describe things. So we can, instead of saying that we're correcting the patient, we can say, okay, this is your volume coaching. Okay, so I'm going to do some volume coaching. So anytime your volume drops, as your coach, I'm going to help you to boost it back up. It helps also to build trust if you have, have looked at what is medical mistrust? What has our patient been through in their pathway to through healthcare? Understanding what microaggressions are. What does dismissive treatment look like? If you have knowledge of those things so that you can be aware not to do those, that also will help you to build trust. And that's a huge thing for marginalized populations. Utilizing shared decision making is also something important. So there's a paper about 2023. It's called Shared Decision Making with Black Patients, a scoping review. Black patients, highly value shared decision making. We want to be part of the healthcare decisions. In this study, only 58% of Black patients reported being involved in decision making with their clinicians. And so this is really important so they know, like, we're all a team. This is not the old medical model where I tell you what to do and you do what I say, but we collaborate on that. Address access barriers. So if you can do, like, you use telehealth, for example, if someone has trouble with transportation, help people find something closer to their community, just, whatever access barriers there are, we see what we can do to help that. Addressing the power dynamics. Again, this kind of goes to that whole coaching thing. So, as the healthcare provider, we are in a power position and we want to make sure that our patients don't feel like we're demeaning them when we're coaching through this, but actually that we're helping them, we're helping their body, helping their brain by the way that we're delivering these services. Another thing I'm getting better at is providing extra resources on finding community and finding support, and also finding about participating in research studies. That's something that I have not routinely done within the context of my therapy. So now I'm trying to do that more. We can pay more attention to mental health challenges, especially, again, of our females. This is going to be a huge thing. It's big for all of our patients with Parkinson's, but females in particular really struggle with the mental health challenges. So if we could help someone tap into a community, into resources, that would be very beneficial for them. And then another thing I've started doing is I've started sharing information about hormones and symptoms. In the past, I never thought to ask someone, like, where they were as far as menopause, if they're having cycles, and how do those things interplay. But one of the patients I have, we realized that actually she was seeing some fluctuations related to, her cycle. For her, that was eye-opening. She, was like, oh, it's not in my head. I was like wondering, like, why are these things happening? And no one had ever told her that there could be a correlation between those two things. The slide before this, I had, this is just a list, like, what would I do if I had a family member diagnosed with Parkinson's? This is something I'd like for you to maybe share with anybody that you might know that is newly diagnosed. Just a few tips for things that will be beneficial. And then we will have time for a question and answer, but I just want to say, here's some contact information for me. There's my email address. You can also send an email through LSVT Global. If you're watching the replay, you can find me on Instagram. If you have questions or just need some additional information. There's my image credit. I did have Dr. Bell's permission to share her video. And then you have the references separately. So we will do some Q&A now. Try to stop the share. My mouse has gone away, so stop it. There we go. Okay. All right.
Well, thank you. I mean, that was amazing. I feel like you shared some really wonderful resources and tips.
Yes.
Any questions I was going to have, I feel like you were addressing them. So I know that the audience has really gone away with some great information that they can, if they're clinicians, work into their own practice as patients. I think Dr. Bell was such an amazing just testament to what we're missing out on. And it sounds like, it took a long time for her to be diagnosed, and she had to seek it out herself. And I think it really shows that they want to participate and they're willing to, and she just couldn't find anything. And so I guess with that, so my question, and then we'll open it up to other questions too, how do we make sure that we're giving the information in the right places? I know you mentioned you've started, talking about research studies with your patients now so that they know that's available. But clinicians, other healthcare providers, what can we do to make sure that we're reaching the people that want to be participating?
Yeah, I would say tap into your local Parkinson's organization. So, like, I volunteer with the Parkinson's Foundation, and it's not that you have to become a volunteer, but all the foundations really are trying to spread the word with the community programs that they have. But yeah, it's hard to spread the word when you don't know like the individual clinician. So a lot of times, like they'll reach out to neurologists. That's always the big thing. We'll talk to the neurologist, but that information sometimes just stops there in the neurologist email inbox and doesn't get disseminated. So going out and finding out, like the American Parkinson's Disease Association, the Davis Finney Foundation, the Parkinson's Foundation, the Michael J. Fox Foundation, is especially finding out about the local things. Because it's one thing to send people to webinars, but people really like to have like that local network where they can go, they can talk to the doctors that are actually in that city where they're living. So that's, that would be the first thing I would say. So that way you don't have to go looking for information. Like you just tell them, I want your information, and they will, put you on the email list, and they will make sure that you get that. So that's probably like the lowest stakes way to do that. But getting involved is the best way. So actually getting involved in the community and actually volunteering and going to the churches and talking to people at the churches about like their health ministries, because a lot of churches do have a health ministry. So if you can meet those people, then you can get some information in, or maybe do presentations to talk about that.
Yeah, great ideas. Thank you. We've had a couple other questions come in, and I'm just going to remind the audience, if you have a question, you can type it in that Q&A box and I'll see it, and then I can ask it to Valeria. You can also raise your hand. I'll see that you have a hand raised, and I'll call out your first and last name to let you know that I'm unmuting your microphone. So feel free to type those in as we go through these other ones. Okay, so we had one that came in. We often find that many physicians don't refer patients diagnosed with Parkinson's to the LSVT programs. We market to the community. However, reaching the physicians is the biggest feat. So they've created their own referral sheets with the information we need and provided to area physicians.
Wonderful. Yes. I think the simpler you make it for the physicians, the better. Yes. So if there's something that they can just like look at that and just put that right into however you do your orders. That's a fantastic idea. Yeah.
Yeah, that was really good.
Yeah. I was thinking, not just neurologists, but primary care. Those are the ones we really need to reach, the primary care physicians, because some of them don't even refer the patients to a neurologist all the time. So they need to know too.
Yeah, that was great. So another big thank you. We've had a few thank yous come through, so thank you. Your tips on culturally responsive LSVT Loud were so valuable. Do you have any post LSVT Loud voice exercise groups? And do you see barriers for Black women with Parkinson's reaching out to join maintenance groups like Loud for Life? And any recommendations on sharing those resources and building trust for them to join?
Sure. Yes. We have Big for Life and Loud for Life where I work. So we do the post-discharge exercise. We've initially our first round of it was we got a grant from the Parkinson's Foundation, and that's one of the best ways to remove any economic barriers is to apply for a grant, get the grant, because then everyone can participate for free if you have that grant. So I would definitely start there. And then once that grant finished and we established the program, we've tried to keep it as affordable as possible. So ours is $35 a month, and that's Big and Loud weekly. So those are the two things. Location wise, like ours has to be where we work. But perhaps like if it's a central location where it's not as hard to access from maybe like, parts of town where there's a larger Black community, that would be also, I think, a good way to improve access. But a big part of it is just people knowing that you're there. So.
Yeah, I love that idea of getting that grant to reduce that economic burden. That's great.
Yes.
Okay, and then we had another one come in. So how can one start a community program for persons with Parkinson's, especially in my country of Nigeria? And this is coming from an SLP.
That's an excellent question. And I'm not sure. So the way we started ours was actually doing like the Loud for Life and the Big for Life courses. And so because that course tells you like how to market, it gives you all the paperwork and all that. So kind of made it a little easier for us. But I know that when I was first looking at like Black women in Parkinson's, I was going into the room to see a patient for the first time, and I was like excited because like, oh, I've been like reading about Black women with Parkinson's, and here's a Black woman with Parkinson's. And then, as soon as we started talking, I realized, oh, she's not African American. She was actually from Liberia. So then I was like, okay, how much of this applies, you know, to the Liberian population? So when I was looking at the information, a big difference between African Americans and Liberians, in particular, and also the studies looked at Nigeria, was access just to the care itself. So it sounds like having access to the medical care and to the community care. But so I don't know the answer to how to do that, but if there's a way, that seems like that was the hugest barrier in those particular studies. I don't know if that answers the question, but I would say if you haven't done the Loud for Life, I would definitely recommend that because it gives you all the tools for that.
Yeah, thank you. And I'll add on, you can also contact us at LSVT Global for training opportunities in Nigeria. So for this clinician that asked that and any others, we do have special programs for African countries, and we have clinicians trained so far in Kenya, Ghana, and South Africa. So you can feel free to reach out to us, and we can look into some of those training opportunities too. Okay. And then I think, so there was another question about the research studies. So you kind of answered this, so I don't know if maybe if you want to expand a little more, but what are your thoughts on how to increase representation in research studies?
Yeah, so was it clinicaltrials.gov is a website that patients can go to, and they can put their information in, and it puts them into a database for potential studies. We get a lot of like emails and correspondence from, I'm in the Atlanta area, so Emory University in particular, and also Georgia State. So when they do studies, they will send us information when they're trying to recruit members for studies. So clinicaltrials.gov is that's the big one, but also looking at if you have some like universities that do a lot of research in your area, or at least within a reasonable distance that a patient could go to, for at least a couple of the visits that they might need to do for a research study. Yeah.
Okay, great. Well, thank you. And I think you've answered all the questions that came through. If anyone thinks of a question after the webinar, again, you can feel free to email us and we can pass it on to Valeria, or answer it if we can, but she's the real expert here. And I'm just going to pull up my final slides to make sure I cover just the final logistics of the webinar, and then we'll let everybody go. Okay, just want to make sure that you're aware of the survey. So if you're watching live, there'll be a survey that will pop up right after the webinar. It will also be emailed about 24 hours after the webinar. If you're watching on demand, there's a survey link below the webinar description, and we can also email that to you if you can't find it. So if you want a certificate for the webinar, for self-reporting for CEU credit, you'll need to complete the survey, and also any SLPs in the audience, if you want us to report this to ASHA for the CE registry, you'll also complete that survey, and then we can make sure that gets reported correctly. And then we also just wanted to let everyone know about a podcast that we've launched. So we've been doing it about 1.5 years now, some great topics related to Parkinson's, all the way from experts to patients sharing their stories and their journeys. And so it's a really nice spectrum of stories and important information there. So feel free to check that out. Just wanted to end with a big thank you. So thank you, Valeria, for taking your time to share this important topic with us. I know that we took away a lot of great resources and tips. So thank you for sharing that. Thank you to the audience for being here. And do you have any final words before we part ways?
No, I just want to thank you for this opportunity to share this information.
Well, great. Well, thank you. And so big thank you to the audience, and we hope to see you on another webinar. And I hope everyone has a great rest of your day. So thank you.